Where we are with persistent atrial fibrillation ablation today, in the light of the STAR-AF2 data that demonstrated that a lot of what we've been doing over the last few years is actually not particularly effective. STAR-AF2 was a study that was published in the New England Journal last year. Atul Verma from Canada was the lead author, and it demonstrated that isolation of the pulmonary veins alone was as good, if not trending to be better, than isolation of the veins plus extensive further ablation in the atrium, be that either linear or what we call cafe ablation, ablation of fractionated electrograms. In the light of that study, it's difficult for us to know what to do with a significant proportion of our patients with persistent AF. Fortunately, the success rate of antral isolation alone, at least at 1 to 2 years of follow-up, seems quite reasonable. But there's obviously a lot of ongoing interest as to what we should do next. It is, as others have said before me, it's a moment to hit the reset button. There was evidence that these things worked, but it was largely from smaller trials and meta-analyses, and I guess there's a strong imperative to help people when they're unwell, and so on the basis of that information, it was understandable that these procedures were being offered. But then you get a large multi-centre independent follow-up randomised study that shows actually no benefit, that makes us all sit back and reevaluate where we are. I think the message today is we've got a few things on the horizon. Mapping and ablation of rotors, modification of the substrate in the atrium, but perhaps this has been a sobering lesson for us all, and that we should not rush towards these until we've got good trial data. You do what's safe, and you do what's been proven to work up to a point, and that is antral isolation of the pulmonary veins. Many of us do a very wide area encirclement. There are others that add things to this, chasing non-pulmonary vein triggers, isolation of the appendage. But again, I think these have not met the trial requirement that they would be widely accepted and widely performed in the field. The impact of risk factor modification on AF outcomes, both with and without ablation. What my colleague in Adelaide has really shown in a series of very elegant studies is that there is a strong relationship between overweight and obesity and atrial fibrillation. There's a lot of epidemiologic data in support of this over more than a decade, but the recent data coming from Adelaide trials that we've been fortunate to participate in demonstrate that if you are successful with very substantive weight reduction, then outcomes following ablation of atrial fibrillation are significantly improved, and that some patients in the lead-in phase to ablation improve so much that they actually fall off the waiting list. Those are studies that have largely been published in the Journal of American College of Cardiology last year. The ARREST-AF cohort study, the Legacy study, and before that a randomised study in JAMA in 2013. But it should also be added that much of the more recent data are observational, and that this remains a certain amount of skepticism that we can successfully get the majority of our patients who are overweight to lose weight and maintain that weight loss. Obviously that's been a holy grail in the obesity community for a long period of time, and this has been achieved to date in dedicated risk factor management clinics. It's certainly completely ineffective, as we've discovered, to sit in the office on one occasion and say you need to lose weight and here's what you need to target. We've found that to be largely ineffective. But if you give the patient detailed strategy, detailed dietary assistance, and very intensive follow-up, short-term goals, repeatedly follow them up. We've had people from the clinic contacting patients on an almost weekly basis to look at the levels of activity, look at the balance of their diet, look at what's happening with their weight, and all of their other risk factors. Then, you actually can get a result. And the point being, as patients lose the weight and feel better, and their AF severity, in at least a proportion, is significantly modified, they become very much more motivated. It's not a straightforward relationship. There are those who lose the weight and their AF really dramatically changes, and those who lose the weight and continue to have AF and continue to require an ablation. But I think the global picture is that if you don't address the issues that are responsible for the atrial fibrillation in the first place, your intervention is much less likely to hold in the longer run. I think, as I mentioned, with weight reduction, people are really waiting to see prospective randomised outcome studies post-ablation, and those studies are ongoing. And I think the big question is whether, this has been performed in a number of centres, whether this can be very broadly achieved and more widely generalised. Will this type of aggressive risk factor management clinic sort of take off internationally, and will people see the value, and will it be more widely successful? And I think they're big questions.